Hello, my name is Kelsey, and I'm going to be doing my presentation on Marfan syndrome. For the background, Marfan syndrome is an autosomal dominant trait, which means that it only takes one abnormal gene from either parent to have the condition. So that means that it doesn't matter if it's the mother or the father that has the gene, either one, if they have it, that gives the baby a 50% chance of developing that disorder. Marfan syndrome was recognized in 1896 by French pediatrician Antoine Bernard Marfan. And Antoine Bernard Marfan described it as skeletal abnormalities like overgrowth and joint laxity. The first person that was diagnosed with Marfan syndrome was a little girl for the reason that she had abnormally long fingers. And in 1986, the official diagnostic criteria was defined by the Berlin Nosology and has been reviewed twice since, because medicine is always changing and new things can always come up, so it's important that we keep reviewing those kinds of things. For the etiology, the most basic way to describe this disorder is that it is a defect or a mutation in the fibrillin 1 gene. And just to give you a little bit more of a background on what fibrillin 1 is, the fibrillin 1 gene is responsible for giving instructions to produce the fibrillin 1 protein. Fibrillin 1 is a component of microfibrils, which are located in the extracellular matrix, and microfibrils are what form connective tissue. So as we know, connective tissue is found in many parts of the body, like tendons, the ciliary zonules, which hold the lens of your eye, arteries, skin, lungs, and many other places. And fibrillin 1 also regulates the transforming growth factor beta, which is also known as TGF-beta. And TGF-beta is a small protein that stimulates tissue growth. For the pathophysiology, I wanted to include an image just so that you can properly see what's going on in the body when it comes to Marfan syndrome, and you can kind of compare it to a normal microfibril. So with a normal microfibril, you can see that it is fully intact on the top of this image here. You can see the fibrillin 1 that is located on the microfibril, and that TGF-beta that is, again, like I said, regulated by the fibrillin 1. So the mutation either makes fibrillin 1 dysfunctional or less abundant, which in the end causes the microfibrils to be dysfunctional as well. In turn, this causes low tissue elasticity and integrity, as you can see at the bottom of that image in Marfan syndrome. That is basically what it looks like. So in addition to the tissue elasticity, loss, and integrity, the TGF-beta is not being removed by that fibrillin 1 mutation, which causes more tissue growth. Most of the signs and symptoms of Marfan syndrome can be explained very simply by one thing, and it is the weakened connective tissue from the mutation, which I explained with the pathophysiology. And so if we think back to our anatomy and physiology class, there's a few different types of connective tissue. So there's the dense regular connective tissue, which is found in your ligaments and tendons. There's your cartilage, there's bone, and then there's also the dense irregular connective tissue, which is found in your skin. So when you think about it, if all of their connective tissue is weakened because of this mutation, that is a lot of things that can be affected by it. So one of the signs and symptoms is Marfanoid body habitus, which is when they are extremely tall with long arms and long legs caused by the overgrowth of their bones. There's arachnodactyly, which is long, thin fingers and toes. There's the pectus excavatum, which is when your ribs sink in, and pectus carinatum, when your ribs point out or your chest points out. You can also have scoliosis, which is when your spine curves abnormally because the ligaments in the spine are so loose that they can't hold the vertebrae in place. The inability to extend elbows 180 degrees. They have extremely flexible joints because it also affects the ligament tissue, making them loose and more flexible. And then they can also have a downward slant to their eyes and a narrow palate. In the skin, people with Marfan syndrome can develop stretch marks at a very young age and without even gaining any weight. Some of the other body systems that are also affected by it are the lungs, in which they can develop bulla, which are air-filled sacs that can rupture within the chest cavity and cause a spontaneous pneumothorax. The eyes, where they can get retinal detachment, lens dislocation, and cataracts. And then the cardiovascular, which is probably the most important one, which they can get aortic dilation, which can cause the blood to leak back into the left ventricle due to the valve insufficiency. They can get cystic medial necrosis, which is damage to the muscle, collagen, and elastin of the aorta. Because of the damage to the aortic wall, this can cause it to be more susceptible to aneurysms, to ruptures, and dissections. And then they can also get mitral valve prolapse. For the treatment, currently there is no cure for Marfan syndrome. The treatment mostly depends on the clinical features because there's various complications that can arise from it and not everybody is the same. So for people with Marfan syndrome, they'll often need to go for various tests like echocardiograms so that they can see the condition of the heart valves in the aorta, as well as going for ongoing eye exams like the slit lamp exam, which checks for lens dislocation, cataracts, and detached retinas. They'll also go for the eye pressure test that we all hate so much, where they blow the air in your eye. And then some of the big treatments for the signs and symptoms, they can be put on medications like atenolol, which is a beta blocker to help prevent the aorta from enlarging and also reduce the risk of rupture or dissection, and these lower your blood pressure. They can also be put on angiotensin receptor blockers like losartan, which decreases the TGF-beta signaling, and it can also help prevent that dissection or rupture. Some of the surgical repairs that may need to be done are aortic repairs, which is when the aorta's diameter reaches about 2 inches or enlarges too quickly. They'll want to go in and replace it with a tube made of some synthetic material, and then they also possibly may replace the aortic valve. And so they might also need to treat the scoliosis, which involves bracing or surgery to repair or minimize it. And then they may also need eye surgeries to repair torn retinas. They may need to get an artificial lens put in to repair cataracts. The breastbone corrections is more a cosmetic surgery if the patient doesn't like the look of their breastbone. So for my test questions, the first one is a mutation in what causes Marfan syndrome? The second test question is a true or false. People with Marfan syndrome are more susceptible to spontaneous pneumothorax due to air-filled sacs called bulla that form on the lungs. And the last question, which of the following is not a sign or symptom of Marfan syndrome?